Hello, welcome to CARDIA, the program dedicated to the understanding of the human heart. I'm Mark McDonald, as always joined by Dr. Greg Mishkel from the Prairie Heart Institute. Doctor, thank you.
Mark.
We're going to venture into the field of electrophysiology a little bit during this program. And for those who don't know, that is the pacemaker, defibrillator, the portable sort of devices that people can wear on them.
Right, and as I've explained to you in the past, there are two trade unions predominantly in cardiology. Mm-hmm. There's the plumbers and the electricians. Mm-hmm. And we spend a lot of our time talking about plumbers because I'm a plumber.
That's you.
That's me. But this is a different trade union and a totally different pay scale. We're going to talk about the electricians.
Right. And there are only like 3 in your practice, I think, that are electrophysiologists.
No, we have actually in our practice 5 electrophysiologists. This is really a booming field. Mm-hmm. 5 electrophysiologists. There's another 1 or 2 in the city as well. So there's about 6 or 7 electrophysiologists in town now.
When we talk about arrhythmia, and that's what a large part of what these doctors do is treat arrhythmia, that's when your heart, the beating of your heart gets out of whack and it doesn't time itself correctly.
And in many instances, they require devices that come with batteries or leads, and in many instances, those batteries run out or the leads have to be replaced.
Yeah, and in the case we're going to see here, we're going to visit with Dr. Ziad Issa, one of your partners, and he's in a situation where he's had one of his patient's defibrillators has gone out for whatever reason, and it had to be removed. Well, one of the difficulties in removing a defibrillator is that the leads which go into the heart have to stay in there because you can't just yank them out. Sometimes these defibrillators will get infected or there's another problem with them, and then when they have to be removed, it can be a problem. Well, there's some new technology now. A doctor or a surgeon doesn't necessarily have to go in with a scalpel to remove these leads. They can be done by laser, as Dr. Issa explains. Well, Dr. Issa, our patient today has a situation where he had a defibrillator.
That's correct.
And it was removed, but he developed an infection on the leads.
That's
and it's
correct.
typical, isn't it, when you remove a defibrillator or a pacemaker, to leave the leads in the heart because you just can't get them out that easy.
That's true. The leads over months to years, scar tissue binds on those leads into the blood vessel and the heart wall and make them very stuck to those structures. Just pulling on the leads will not get him out. They might break him, or even worse, might tear a hole in the blood vessel or heart.
And you don't want that to happen.
No, not at all. And so we get him out only if we need to. And infection is a very good indication or reason to get those leads out. It's a challenging process because freeing those leads from the binding scar tissue in the blood vessel or heart muscle is a very challenging, very difficult, and until recently, conventional methods used to be risky. Many patients would have a tear in the wall of the heart or blood vessel that causes fatal bleeding or need for emergency open heart surgery. Some make it, some do not.
Right. Our patient today said it's okay for us to be in the procedure, and what you're going to do is remove those leads with a laser device.
That's correct.
Which means you don't have to go in and cut that out of there with open heart surgery, which is a great advancement.
That's right. That's right. We're lucky and fortunate over the last few years that we've been using laser energy, which is a cool energy. It is applied to cut through the binding scar tissue and free the lead from the wall of the blood vessel, similar to the laser used in eye surgery.
If you would, first show us what the defibrillator looked like and the leads so people can sort of visualize what it is you're dealing with.
This is a pacemaker. Pacemakers are devices we use to protect patients from very slow heart rhythms. This is a defibrillator. A defibrillator will have a capability of a pacemaker, so it will pace the heart and protect it from slow heart rhythm, but it has another function, which is shocking the heart that goes in a very fast rhythm that can cause cardiac arrest. A pacemaker cannot do that. A defibrillator would.
Now, our patient today had the defibrillator removed.
That's correct.
And as we described, though, these leads, which actually go into the heart vessel, am I correct so far? Go into the heart vessel.
That's correct.
This is what does the regulation for, or the defibrillating for the patient. These leads here connect to the heart.
That's right. These devices that can here will have the battery and the computer circuits. But for the device to interact with the heart, sense the heartbeat and pace the heart or shock it, it has to deliver it through those special wires. We call them the leads. We usually use the blood vessel that carries blood from the arm to the heart. We use it as our tunnel to tunnel these leads and get this tip into certain chambers of the heart muscle.
In our case today, those leads are still in there. They've become infected. They need to be removed. And this is the laser device over here that you're going to use.
That's right. This is a sheath, which is a hollow tube, plastic hollow tube. One end of it will be connected to the laser generator. And we pass the lead through this sheath. So, for example, we get the free end of the lead in the shoulder through the sheath, and we apply laser to cut around the lead, this wire, and free it from the binding scar tissue. This laser has low penetration, so it cuts only a fraction of a millimeter at a time. So we avoid injury to the wall of the blood vessel and the wall of the heart by doing so. We apply energy all through along the lead until we free the whole lead to the distal end in the heart from the scar tissue, then we pull it out.
Okay, you pull it out, and it comes through the same sheath that the
Yes.
laser was sort of freeing it, and then
That's
you pull it
correct.
out. What about the scar tissue that, I imagine you've chewed up some scar tissue in there at the same
Yeah,
time?
laser
haven't
cuts scar tissue in very fine particles that's absorbed in the body. Some scar tissue will be stuck still to the lead, and that will come out with the lead itself. But it doesn't cut any pieces from the lead that would go into the bloodstream and can be hazardous.
you? What a remarkable advancement from having to go in there and with a scalpel and to cut those leads
That's
out.
right.
Yeah.
Now we don't need open heart surgery to do that, and we don't need risky sheets that can tear holes in blood vessels or the wall of the heart.
Well, thank you so much. I'm looking forward to seeing you actually do the procedure today. It'll be an eye-opener. Thank you.
Thank you. You're welcome. The lead has very fine lumen that we can push past this stylet inside it. So this way I can pull on the lead, more handle on it. The sheet will go over the lead and cut the binding scar tissue from around it. Okay, this lead, we freed it all along from the scar tissue, so we're going to pull it out from the sheath. Hold here. This is how the lead looks like once outside the body. All that around it is the scar tissue that's being cut. It's the white tissue that binds the lead to the surface or the wall of the blood vessel. And this has been cut by the laser machine. And the lead is completely freed from the binding scar tissue, and we can pull it out. And this is the lead. In. We clean it from the blood. The lead has a lot of growth of scar tissue. You can see here. This is all scar tissue that binds the lead to the wall of the blood vessel and the heart. And that doesn't let us just pull the lead out. We have to cut through this scar tissue to free the lead from the wall.
Well, in the old days, Dr. Mishkel, when a surgeon would have to go in and retrieve those leads, as we said, it would have been more problematic. But you tell me that oftentimes that didn't occur at all.
Well, unless it was absolutely imperative to take the leads out, it was a big deal to take out leads. It would require sternotomy, breaking the chest, and opening up the heart, sometimes putting the patient on the heart-lung machine. A pretty morbid set of circumstances, and for the most part, leads, if they weren't infected or there wasn't some compelling reason to take them out, were left behind. So, you know, I have seen in my career patients with 3 and 4 leads left in their heart, and there can be consequences from that. So generally now with this new technology and the ability to take out the leads, in many instances, even if there wasn't a compelling reason, like as there was in this case with the infection, we will take the leads out rather than leave a lot of hardware in the heart, which could act as a conduit for infection in the future.
Now this patient could go home, say, next day if everything goes
Correct.
well. What about if you have to do the open heart surgery?
Well,
You're talking about a considerably longer period.
It's open heart surgery, and they'd be in hospital for 3 to 4 days, assuming no complications, and then obviously a convalescence related to healing of the wounds and just getting over general anesthesia.
Wow. Well, you know, we have brought in a special guest today. You and I have been talking since we did this program, at least for the last few years, about the possibility of doing one on dental hygiene and the relation of gum disease to heart disease, because as we go through the literature, we find more each year that sort of, I wouldn't shows a causative or correlative effect, but there are corresponding issues, aren't there, with health of the gums and health of the arteries?
There's a lot of overlap between medicine and dental health, and we're learning more, and today we got an opportunity to learn from an expert.
Right, one of the few periodontists in Central Illinois. Dr. Phil Wheeler, thanks for joining us.
Thank you,
it's
Mark.
great to
Thanks
have you
for
here.
asking me. Thank you very much.
Let us start by asking you, and I asked you to do a little prep work on this. In fact, you and I have been talking about this for several months.
Yes, we have.
About...
He's going to bill you.
Well, I know what that's like.
Yes.
And I'll wait for the check.
Okay.
I'll wait for the check.
About the correlation between artery disease, heart disease, and some of those issues that you might find also as well in gum disease. And that's
Exactly.
what a periodontist specializes in,
Yes.
is gum and the tooth disease below the gum, I guess.
Exactly, thank you. One of the findings were that in the investigations, we weren't able to uncover, not able to uncover a causative effect between a local disease pattern of periodontal disease and a systemic disease pattern, such as cardiovascular disease. We didn't get a causal effect, but we see enough of the red flags, if you will, coming up along the ways that a lot of investigators thought that the best thing to do at this point is to check it out, to see what the implications of periodontal disease might be to something that's more life-threatening in cardiovascular disease. As we know, periodontal disease is a disease of inflammation and infection. If it's involved in the gum tissue, we call it gingivitis. If it's involved in the deeper structures, we call it periodontitis. We used to think in terms of this disease pattern being a degenerative disease years and years ago. We thought that tooth loss was a result of just old age.
It was inevitable.
Inevitable, you're going to lose your teeth and it's going to just fall out. So with investigations, in somewhere around the 50s and the 60s, a long time ago for you young men, but not for all of us, we've investigated and we found that it is a disease of inflammation, infections. Of all the categories of diseases we have, the category of inflammation, infection is where this disease falls. We know then it's caused by and precipitated by bacteria. And it's this bacteria and their byproducts that are leading us to connect this local periodontal disease, a local disease pattern, to a more systemic disease pattern, that of cardiovascular diseases. And we're now finding some link-ups, some findings that match. There's a match. So Is one related to the other? We think so, enough to at least cause further investigation at this
Now,
point.
you'd mentioned also that in atheroma, or when you find plaque buildup in the body, that you can actually find bacteria sometimes in those plaques.
Some other investigations, and I think it's some studies that were done back in the earlier in the decade, this decade, that they were uncovering the in arterectomies.
Right.
Am I saying that correctly?
Right.
They were able to cover in this plaque that they were uncovering in the atheromas that were present. In other words, that little sac of lipid or fat that's there, they were able to culture it out, and in culturing it out, they were able to find the gram-negative anaerobes that are pathognomonic or causative factors for periodontal disease. So we think there's a strong relationship between those two findings.
And it may not also be just the fact that it's the bacteria, but it may be a response to the bacteria, right? The inflammatory response to the bacteria that
Sure.
may also be leading to plaque
Sure.
buildup.
Exactly. Some of the findings that they also extended into a very large population in this one particular investigation, nearly 6,000, I guess. But as they were going through and finding out the amount of periodontal disease that was present, they were able to say, well, these individuals had cardiovascular events. So let's find out if we can trace these bacteria, and they were able to recover a significant amount, into the 70s and 80% of the times. Antibodies, serum antibodies, so antibodies in the bloodstream, that were related to these bacteria that are, again, known pathogens for periodontal disease. So Dr. Mishkel knows much better than I, and most of us, what inflammatory reactions and what instigates this, what mediators of inflammation can we see. You talked earlier about C-reactive protein that's produced in the liver. At the time that we have this inflammation, these markers show up in the bloodstream, and these are precursors, not necessarily precursors, but signs, early signs that if you have these, you have a problem cardiovascularly.
So essentially, any disease process, particularly in the mouth, which is often a neglected area, can provoke inflammation, and inflammation in and of itself can precipitate cardiac events. So it could be related to the bugs, or it could be related to the response to the bugs at a source distant from the heart.
I bet you very few people think about that when they're brushing their teeth or flossing their teeth, that what they might be doing is preventing a possible heart disease. It's incredible.
Well, there has been an overlap between dentistry and just frankly medicine for years and years. And one of the things that I do in my patients, particularly before they go for heart surgery, particularly before they go for valve replacements, is look at the oral hygiene of an individual. And that oral hygiene should be addressed prior to surgery.
Well, it comes back to, I think Dr. Mishkel and I were talking to this earlier. If we take an approach to cardiovascular disease, and we know that there are some putative factors, in terms of smoking or elevated cholesterol levels, hypertension, things that we all sort of know, I think we can now start thinking in terms of putting periodontal disease, at least the advanced stages of periodontal disease, in this or similar category, to say, let's concern ourselves equally if we have an active infection. Most of the research had clinical findings, but there was no way we could do clinical findings at that time when we had an episode. We had a periodontal abscess, so much more involved in that level to a direct cause, but you can't uncover that abscess at the same time when you're going to get a heart attack. We don't know that's related, but we do know that these happens, because periodontal disease, although usually it's a low-grade chronic inflammation, which is what you need, what's needed to have this disease pattern go on, a low-grade chronic inflammation process, we certainly fit the bill. But at the same time, ours is more of an episodal disease. We don't just get rapid periodontal disease and have a problem here. It cures, it falls back into okay, normal, and then back again. So each of these episodes, and that's, I think, the future of our investigations, to say what happens during this crisis period, and did it have a relationship to something before, or during, or after some cardiovascular event?
Yeah.
So.
We mentioned overall wellness before too, and it's amazing how many people have not been to a dentist, maybe ever, Probably
sad to
not
say.
in several years.
Sad to say.
And these are the same folks who, in many ways, don't take care of themselves and have to start doing that. But really, a good way to start would be, number one, go see a dentist, and maybe number two, go see a doctor if you haven't been doing these things. Because you run into, you can wind up with many of these symptoms all bundled up on you, and then you're really in a mess.
You know, I think part of the issue is that, you know, in many respects, people just view dentistry as one of two issues. Either you don't have a toothache, or you're going for cosmetic reasons, not realizing that it's an integral part of your health care in the same way as you go to a kidney doctor or a GI doctor or your general doctor. You know, oral hygiene has a role in terms of your general health care. And frankly, many of the treatments that we use in cardiology, just even some of the drugs, can affect the gums.
They have to certainly be considered. If any collateral treatment has to be considered with what we're doing, with what the patient brings to the table, or in this case brings to the chair. But we have to sort of correlate what medications they're on for whatever reasons, and deal with that in accordance with our treatments.
Yeah, and these these infections travel so fast and then grow, I guess, so quickly. You were talking about if you have somebody who you're going to refer for a heart valve, that person better not have an infection in their system.
Correct, and you want to, and you don't want to have an infection in your system when you put the heart valve in. So that has to be taken care of prior to having.
And it could very
major
well be in the gums.
Absolutely, and you know, not a month goes by that I don't have 1 or 2 or 3 conversations with a dentist nowadays about the health of shared patients.
And that's kind of a new phenomenon, isn't it?
It is. Yes, it is a new phenomenon.
Phil, you were mentioning earlier, and I get a kick out of this because you've mentioned your age a couple of times here and how young we are and how, but in your career.
We're going to invite him back.
Yeah, that's right.
He makes us look even younger.
In your career, you've seen great advances in periodontal
We have indeed.
medicine, haven't you?
Yes, we have. Yes, we have.
Even more than in maybe as much as in cardiac care.
I think it didn't do quantum leaps. It was sort of one of those things that's progressive, but we were in those lines of discussions years ago. We would have considered 90% of the population of the United States would have had some form of periodontal disease.
You said 90.
90.
90, wow.
90% years ago. Back in I think it was a Mays study, Dr. Mays did a study back in the 1950s. If you did that same study today, you'd find 2 out of 3, so maybe 60% as opposed to 90. Now in that segment, you will find maybe only half of those individuals have the level of the periodontal disease that concerns Dr. Mishkel and I, to the level that there might be some crossover in the 2 disease patterns. So we've really come a long way with putting the emphasis on good dental health, good general health, and for the most part, people are responding, but we'd like for more of them to do it. I mean, it doesn't take much to say to yourself, as a part of my health pattern, I'm going to go to the dentist, and I'm going to find out what my baseline is, what my baseline of health is, oral health, and fix what's there, fix what you need. Because in the long term, it's going to do you some good.
Yeah. And you, one of the first things I guess you recommend to somebody if they come to you and there's in some kind of a crisis, because you don't just call your cardiologist if you're just fine. One of the things you really want them to do is get their general health checked up, don't you? I mean, and a GP and a dentist would be the place to start.
It is sometimes amazing to me the number of patients that we see who have no family doctor, have no dentist, and they'd like for you, the cardiologist, to look after their general health, but we can't do that.
Right.
Right.
And you shouldn't be doing that because you have a specialty. Yeah, you have a specialty.
And the specialty isn't looking after, I don't know enough.
Well,
I know this much, that's it.
And it's right
He
here.
knows
Right?
this much.
I'm a plumber and I'm right here.
Right, that's exactly. I'm right
Put me in the same box.
Right.
Put me right there. Put me right there.
Yeah. So you've seen great advances, but even though these are great advances, we're only seeing go from 90% with a periodontal disease to 66 2/3%, which is a lot. That's a large number of people. We're still talking about people with more than half the population with problems that could be avoided.
Sure. Yeah. And we hope that if we take that linearly in a progressive form, we hope to bring those numbers down more and more. But it's a matter now of placing, and Dr. Mishkel and I have talked about this before, we need to continue putting our emphasis on prevention. The only way we're going to get it is not through the dentist office. We can fix, we can repair, but we cannot cure.
Yeah.
There's no cure for periodontal disease.
Yeah.
period.
Well-
So the curative effect, if you will be getting it healthy and then maintaining that. Then you get a curative effect of that treatment, and that's going to bring the numbers to the bottom, where we want them
Yep.
to be.
Very informative.
Sure.
Thank you.
Thank you very much. Thanks for
Dr. Wheeler?
Thanks for asking, Mark.
You
very much.
bet.
I appreciate it.
Dr. Mishkel, thank you.
Thank
and
you.
Dr. Issa, wherever you are, thank you for letting us join you on your procedure and helping us with our interviews for CARDIA. Thank you, the audience, for watching. See you next time.
For a DVD copy of this episode of CARDIA, send $19.95 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, broadcast date, and topic. You may also order with your credit card by calling 800-232-3605 or by using our secure server by going online to networkknowledge.tv.